Yeah, please. And one of your patients came, like who you have done stem cells in.
Okay, we are live.
Yeah, sorry. Okay. So welcome everybody for this session on DHEA and coenzyme Q10, the role in fertility. So as fertility specialists, I think we are bound to do the best that is possible for the patient, and we tend to overdo with our prescription of medicines, right from vitamin D to the L-arginine to everything under the sun. I think the IVF patient will be taking it. So this class is to just give you a scientific perspective as to what really works and what doesn't. And these are the two molecules which are very popular, available in the market today, which is overused by the fertility specialists. One is DHEA and the other one is coenzyme Q10. So many of us don't want to leave any stone unturned when we are giving the results. So this is just another perspective as to what is the scientific evidence at present to prescribe such medications, which might increase the cost of the IVF stimulations. So over to you, sir. You can take over.
Yeah. So before I start to share the screen, let me first discuss the scientific evidence. Okay. Scientific evidence in view of DHEA is a biased evidence. It has been scientifically proven that there is bias, okay, in the evidence. And scientific evidence for CoQ10 does not exist, okay, because it is studies done on mice. Practical purpose is that if you don't want to watch the class further, it's very good. Just remember that there is no role of giving these drugs as far as increasing low AMH is concerned. There is no role of giving these drugs in patients who are with unexplained infertility. There is no role of giving these drugs to improve the embryo quality. There is no role to give these drugs in poor quality embryos. There is no role in giving these drugs in empty follicle syndromes or anything else. Okay. So joining me is Dr. Sachin Dalal. He has just come to my house. So he's right here. And he's also listening to the masterclass right from the front. So I'll now start to share the screen. And we will go straight to the topic. So role of DHEA and coenzyme Q10 in low AMH. Okay, or I would just place it in fertility. Okay, so basically, please remember one thing. Majority of the patients, which majority of the people see, are patients who at the moment can't afford IVF in India, or at the moment don't want to do IVF. Okay, now whenever you have this type of situations, it is important to understand that, as Dr. Shilpa said, that in this people want to try their best. So in order to try their best, okay, whenever you want to try your best, it is important that you understand that in order to try your best, the best thing to do is a good stimulation. Okay, but along with good stimulation, people think that giving some of these adjuvants, especially DHEA and coenzyme Q10, okay, people think that it may help, and because they think it may help, they try to do that. I would also like to negate one more important thing. There is combination of myoinositol and decheiroinositol and all its combinations. Okay, fortunately, they have been proven that they have no role in PCOS patients. All right, so because of that, many companies have withdrawn those sachets, and a lot of the companies who have the sachets still in the market are giving it at a dirt cheap price because they want to finish off the stock. Okay, so now coming to DHEA and coenzyme Q10, let me just touch DHEA first. Okay, so first let me tell you it is a biased evidence. Second, let me tell you it has got no role. Okay, and now then let me prove how it has got no role. Okay, so what does DHEA do? Basically, DHEA in the human body is secreted in the adrenal gland. Where is the adrenal gland located? Adrenal gland is somewhere located above the kidney. Okay, it is somewhere here. Okay, this guy secretes DHEA into the blood, and DHEA goes to the tissue where it wants to act. So predominantly, it is going to go and act onto the very, very, very small follicles. Okay, it will go and act on the very, very small antral follicles. And when it goes and acts on the very, very small antral follicles, it goes and metabolizes into androgenic products. Just remember that much. And for these small follicles to be rescued, you require an androgen microenvironment. Okay, this androgen microenvironment is your characteristic hallmark that you have so many of the scattered small follicles in PCOS. Okay, another, just to give you another correlation with this, because when you have very low AMH, okay, that means the anti-Mullerian hormone response is very poor. That means there is no blocking these follicles from getting stimulated. So the amount of, let's say if the AMH is 1, that means the amount of AMH in the blood is so less that it is stimulating more of these follicles to grow. Okay, so the same thing happens with DHEA. It is postulated that it will increase the androgen microenvironment. A therapy which is given approximately for 2 to 3 months prior to doing the IVF is going to increase the number of antral follicle counts, is what has been projected. It will increase the AFCs. But large studies have been done and it has been shown that there is no such thing which happens. So then you will say, Arey, but I have so much of DHEA remaining in my pharmacy now. How do I use it? Okay. So please remember, you can use DHEA in patients who are these borderline poor responders. Okay. That means these are guys, who are young girls, especially young girls, let's say age less than 33, antral follicle count of, let's say 4 to 5. Okay. In this type of category of girls, if you want to stimulate, you may use it. Okay. I'm just putting a star onto it that you may want to use DHEA. But again, I personally think it has got no role. I have always been a strong proponent of saying that whenever there is anything like this, you should give good stimulation. And if you give a good stimulation, even one follicle, even AFC1 will have a good outcome. Okay. So that is my perspective to this. But this finishes your DHEA. Okay. If you are so curious about giving it, it can be given as 25 mg tablets TDS. So your average dose for the day should be between 50 to 75. And you will of course get people who will say, I have used DHEA in my practice and it has worked fantastically well. Yes, it has, but it has worked for these cases. For AMH less than 1, for antral follicle count less than 4, for age more than 37. Okay, it has any which ways been proven that it has got no role. So let's forget it and let's not debate and waste time. Let us concentrate on wasting our time on something which is even more debatable, that is CoQ10. Okay, what is CoQ10? CoQ10 is basically an antioxidant. Barabar? Fine. So what does this antioxidant do? Now it is believed that this antioxidant fellow, okay, it does something which is very unique. So I'll tell you what it does. Okay, it goes inside the ovary, it goes inside the oocyte. Imagine where all it is going. It goes inside the ovary. So let's assume this is a follicle. Okay, this follicle has got plenty of cumulus cells. All right. Now in one of the cumulus cells as a mount here, in the center is going to be your oocyte. Okay, so it goes inside the oocyte. When it goes inside the oocyte, it causes something called as rescue of mitochondria. Okay, so there is a pathway to explain this. No need to worry. It is a nonsense pathway any which ways. It goes and rescues the mitochondria and it may prevent aging. So by that logic, why should we just use CoQ in the ovary? We can use it on the skin. It should become a beauty product, no? Apply CoQ on your mouth 25 times in a day, you will never age. Correct? Apply CoQ as a male after you cross age of 75 and you will again become 25. Correct? But this thing is, currently the study for this is done in mice. Okay, it has some histopathological correlation, which is again found to be very, very biased. Okay, and as a result of which, all people and all products who are trying to promote this ovarian antioxidants, okay, must try and understand that for somebody to go and cause this benefit, it should actually go and cause benefit to the egg, because it is the egg who is responsible for cumulus cells. It is the egg that is responsible for follicular fluid. It is the egg that is responsible for quality of blastocyst. Okay. And remember one thing about this egg. Okay. This egg, only listens to one factor: age of female partner. All right. Kindly don't forget this, no matter what anybody comes and tells you. As a result of this, in women who have extremely low AMH but are young, the outcomes are better as compared to women who are old and have poor AMH, because it is the age of the oocyte which determines the response of follicular fluid, quality of blastocyst, quality of egg, quality of embryo, everything. It is not the mitochondria inside the egg. And on top of it, if it is mitochondria inside the egg, it is extremely difficult for CoQ10 to actually localize this mitochondria, okay, and go inside the mitochondria of the oocyte out of all people, okay, and give a response. So my simple answer to CoQ10, this is a logical answer. I already gave my simple answer before I started also. The logical answer is, this has got no room. The logical answer is, you want to make a difference to your patient, watch the 75 master classes, because that has covered a lot of stimulation protocols. Okay, and probably Dr. Shilpa is planning to cover a lot more stimulation protocols in the future classes. So just do that, because good stimulation protocol is going to be way more beneficial than even bathing in these antioxidants. Okay. So with that, I conclude. I think Shilpa madam will not have more than 1 or 2 questions, but respecting her age and her birthday has just gone, okay, let us answer 2 or 3 questions from madam.
Thank you so much for making me feel like a fossil. Okay. Anyway, DHEA is a food supplement in US.
Yeah.
So taking DHEA, I think, will it hamper anything? I mean, is there any side effect of giving DHEA?
Madam, often people who have no effects have no side effects also.
Yeah, but how can you say that?
No, I'm telling the fact. That is why it is a supplement.
So you think the money that we are spending on DHEA and CoQ should be given, probably invest it in HMG cycle so that we give them a better quality oocyte, or
No, I don't think that. Science thinks that. That is scientific. Okay.
okay. So many of these DHEA come in a combination of vitamin D3. So do
Yeah.
you think vitamin D3 again is something which is important as an adjuvant?
Yeah. But no, vitamin D3 is otherwise important for the overall cholesterol or plasma health of those cells, not just ovarian cells, every cells, eye cells, brain cells, whatever. So vitamin D supplementation, if you want to give, you just give 1 injection, 6 lakh units. Okay, full family's requirement will finish in that. Why should we give it with DHEA, madam?
Okay. So do you do vitamin D3 levels and then start the vitamin D3, or you give it like a blanket 1 injection, whoever walks into your IVF?
No, we do, madam.
And DHEA again comes in a combination of melatonin.
Yeah.
So again, that is another thing which you don't believe in giving it, like melatonin, you don't think
Actually,
adds.
the response of melatonin has been mentioned in our ancient scriptures. What releases melatonin the most, do you know? Waking up at dawn and doing Surya Namaskar.
Oh, okay.
Okay, that releases much more melatonin than any of the drugs which can release.
Okay, but that didn't answer my question. What I mean. So you has to get up and do Surya Namaskara every day?
No, I'm not asking you to do. I'm not asking anyone to do, madam. I'm just telling you what helps.
Okay, tell the difference between DHEA and sustained release capsules. So now I think the popular ones are the sustained release capsules, which come
Single
in
tablet.
75 milligrams
75 mg single tablet.
tablet. So the difference between DHEA and DHEAS is like DHEAS is longer acting, where the half-life is about 10 to 12 hours. But what we in the SR, I think it is sustained release. I don't know how it works, but don't want to take it like TAD, so they have made this to be more compliant to the patient as once a day dosage. So, since you don't give, I don't think, I mean, you will be able to answer this, whether sustained release is better than DHEA plain, or like both of them
Yeah, I'll
have.
tell you what really works if you want to give. Then you can give testosterone gel.
That
That
was
is much more better.
okay.
Okay. That is much more better than DHEA, madam. But since this topic is not on testosterone gel, I did not mention it. Otherwise, testosterone gel is something which is actually beneficial. And you don't even have to give it like 2, 3 months. You have to give just previous month, anytime. Day 2, day 3, day 5, day 10, day 20, day 16, whatever you can give. And it will help. Basically, before the recruitment occurs, you should give testosterone just in case you want to give.
So, see, there has been a lot of like swinging when it comes to the DHEA. See, once the conference will tell, like, I mean, it is the greatest drug available for poor
Yeah.
responders, and the very after 2 years, it will come say evidence will say that it is not at all useful. So, in this regard, I mean, were you also at some point in time in your practice, were you using it and then you stopped using it because you
So
uh,
I stopped using it from 2018, madam. That is when we stopped using it.
but that was when the paper came.
No, but we had stopped using it in 2018. We had actually taken it. There was, I don't know which company it is, but I know the brand name. Okay, it is something called Oviga DSR. I don't remember which company it is. Okay, and Alembic, correct. And we had placed an order, so we finished the commitment. But after that, we found that it is not very useful.
Okay. So as you said, so it works better in borderline poor response,
Only in that.
only in that. Like, have you noticed any difference between younger patients and older patients, or it is the same with both of them? Obviously, like age being a most important factor in determining the fertility. I think it is safe to assume that, like, it works better in younger patients. What is your
I I don't know, madam. I think so.
Okay, and since you do so much of endometriosis clearance, so with that comes again another part of endometriosis clearance, that low AMH. So in these patients, do you think, like, giving CoQ or DHEA, do you believe in that?
No, no.
Actually help, especially the CoQ, because there is endometriosis, which again we don't know the pathophysiology, and surgery just treats the disease, but it doesn't treat the pathology, or like, the underlying pathology. So do you think adding CoQ 10 to the Dynogest or GnRH agonist, or any other form of
No,
drug?
no.
Not really. Okay, so one of the other things which was discussed in that important paper which came out in 2018 was supplementing DHEA for 2 to 3 months before the stimulation can help in like, reducing the dosage of gonadotropins. I mean, that was the one of the things, like it makes the ovaries more I think receptive for the stimulation process. Have you noticed that? Do you think like it is true?
Not possible only. DHEA is going and acting on antral follicles who don't have FSH and LH receptors. So how it will go and help dosing? Simple mathematics it is.
Yeah. So thank you. And the cost of these drugs are quite, like, I mean, I think it is quite considerable when we talk about it. Like we see a prescription from, I think many of the IVF centers where the patient will be taking at least, like, 12 to 15 medications. So in your practice, apart from gonadotropins and letrozole, what are the other, like, few medications that you would give it as a standard, like to improve?
Progesterone gel,
No, no, during stimulation. Yeah, that comes a little later.
ecosprin, madam.
Okay. Okay. And so do you think DHEA will work in cases of POF, like in premature ovarian failures where we are giving donor oocytes for FET? Do you think, I mean, it can help in endometrial receptivity with the increase in the testosterone somehow? You don't think so?
No.
No? Okay. And Yeah, so for female fertility, you think CoQ doesn't really help at all.
Yeah,
You think
it
it does?
doesn't help.
Do you think it really doesn't matter if the mitochondrial health is improved with the CoQ? It is energizing the oocyte and it will help in kind of fertilization and good quality embryo.
See, I think all this is just ullu banane ka dhanda at the moment. Okay. How can you look at the mitochondrial quality of a oocyte which you can't see on a follicular study where mushkil se you are able to see the follicle and then thinking, oh, CoQ10 went and improved it. What yaar? All such types of things. It is like telling that, you know, you can't laugh like this. But all these things are like, telling that I have married Aishwarya Rai. How it is possible, madam? You know, it's not possible, such type of things. Come on, yaar. Don't just ask time pass questions just to prolong the class to 20 minutes. Please.
They are genuine. Come on, I studied for 1.5 hours just now.
Yeah, but the answer to everything is no. I told, right?
You can be a little gentle and nice about it. Not
Okay. So based on statistical, what is it called? Based on scientific evidence, these things have not been found to make a statistically significant difference in improving the quality of outcomes of these women with low AMH. Happy?
Yeah, thank you so much. Yeah, I think
Yeah.
we come to the end of this class. So finally, the bottom line is make your stimulations better. And I urge everybody to watch the stimulation protocols classes that we have done in the past, ranging from low AMH to PCOD to PCOS in various situations. I think that will give you a lot of insight as to what really goes into, like, to improve your stimulation protocols, which is one of the very important factors determining your IVF success, and make your IVF cycles a little more cost effective when it comes to, using these adjuvants. So thank you, Dr. Jai. After a very long day, I think you still have this energy to come and do the class. I think